So good morning, everyone. My name is Ting. Thank you very much for the introduction. Today, I'm going to go through the impact of drug interaction and polypharmacy with antimicrobials. I'm going to go through some impact of the CYP enzyme on drug metabolism today and go through some common drug interaction with antibiotic against the diet and common medication. Some discussion about like the seizure risk and QT prolongation with antibiotics. Also, what antibiotic that we should be avoid in myasthenia gravis. Also, some interaction between antifungal and some common medications. So first of all, I just want to show like there is a lot of antibiotic. They affect the CYP enzyme. They could be either potent inducer or potent inhibitor. It affects many of the substrate, which is the common medication that we take. So if you look at the potent inducer, we have like rifampicin, and we have quite a few like antimicrobial, which are potent inhibitor, including like ciprofloxacin and our macrolide and our azoles. So there is many interaction between antibiotic and other medication. So with the antibiotic and diet, so alcohol can interact with metronidazole. The effect or after your last dose of metronidazole, you should really avoid alcohol for 72 hours because it's enzymatic reaction. So it might take some time to clear the metronidazole or the enzyme. Patient, if they take alcohol and metronidazole together, they will feel sick and have hot flush and headache. Patient with history of heavy drinking, alcohol could also reduce efficacy of doxycycline. Some antibiotics are particularly poor on absorption, so having food with flucloxacillin and rifampicin might affect the absorption. Doxycycline and ciprofloxacin, they are interacting with dairy products, so giving dairy product with doxy and cipro could decrease the absorption of the antibiotic. We also need to be worried about like the theramine intake with MAOI, which linezolid is one of the MAOI. It will increase the risk of like raised blood pressure. Not just with our diet, but also with the common drug interaction. A strong inducer like rifampicin will reduce the efficacy of the contraceptive pill. Also, rifampicin will affect the warfarin, the INR. However, if you give a strong inhibitor like to CYP enzyme, the macrolide will, on the other hand, increase the INR of the warfarin. Strong inhibitor like macrolide will increase the risk of myopathy with statins. And there is a lead from MHRA and the to highlight the quinolone and steroid risk of tendinitis when given together. We quite often like use doxycycline and rifampicin together, but many of you might not know that like the doxycycline clearance actually double by rifampicin if you give them together, and also the half-life of the doxycycline will reduce. There's also like some synergistic toxicity with different medication, including like aminoglycoside and loop diuretic. It will increase the ototoxicity and the risk of AKI. So other medication like trimethoprim and methotrexate, they work like very similarly. They are like antifolate. If you give them together, there is a risk of increased bone marrow suppression. Antibiotic with seizure. So really all antibiotics have association like with the CNS system effect. So although it is uncommon, but this can be serious. So the most potent seizurogenic effect is exerted by like penicillin, cephalosporin, fluoroquinolone, and then carbapenems. So patients with risk factor are more susceptible to the antibiotic-induced seizure. there are potentially interaction between the antibiotic and the anti-epileptic drugs. So this table just to show like there is quite a few interaction between the antibiotic and the anti-seizure drug. So if you give like ciprofloxacin or quinolone, it does like reduce the seizure threshold, and it does also reduce the metabolism of the anti-seizure drug like phenytonin to increase the toxicity. The same for the macrolide. There is also one quite important interaction with carbapenem with valproate, because it's an enzymatic reaction. If you give carbapenem with valproate together, the plasma concentration reduced by 66% within 24 hours. So basically, it's blocking the valproate. If you give meropenem with sodium valproate, then it's sort of like making the sodium valproate not effective. The next thing I want to go through is like to go through the antibiotic with QT prolongation risk. If you can see like many drug, not just like the individual drug, but by drug class, they have like the property of like QT prolongation. Particularly the antibiotic, if you look at our macrolide, and the quinolone, they are, and the azole, they all have like QT prolongation effect. So the concurrent use of more than one drug with QT prolongation property, then there is an increased risk of toxic point and also ventricular arrhythmia. So some drugs like do not prolong the QT interval themselves, but they can increase the risk of the QT prolongation by affecting the metabolism of the other drug, like the macrolide and antifungal, which affecting the CYP enzyme. Another effect on electrolyte, like hypokalemia or hypomagnesemia, also can increase the risk of QT prolongation, such as diuretic. So the risk factor for QT prolongation, including like electrolyte disturbance, bradycardia, this is like the modifiable risk, or the other drug can prolong QT interval. However, there is some underlying condition from the patient that we cannot modify it, including like the underlying cardiac condition and thyroid disease. So what can be done to minimize the risk of QT prolongation, to consider the risk of QT prolongation when starting new medication? That's quite often when we initiate like quinolone for our patient with deep-seated infection. So we quite usually do the baseline ECG to look at the QT interval, assessing the risk factor for patient, and then avoiding any other medication, and avoid starting patient on prolonged QT drug with congenital QT syndrome. And if we can correct any modifiable risk, like the electrolyte imbalance, then it would be preferable. So the next slides, I'm going to go through like some of the antibiotic that could exacerbate like myasthenia gravis. As I mentioned earlier, like quite a lot of antibiotic can act on the central nervous system. So quite a few antibiotic here can affect the neurotransmission, like the aminoglycoside, the fluoroquinolone and macrolide. They can exacerbate the symptom of myasthenia gravis. So they are contraindicated. The one that in the red bar, they shouldn't be used with in patient with myasthenia gravis. However, there is some drug in the yellow bar which is more cautious. Then they are not as strong as a neurotransmission blockage drug, so they can be used, but that need to be monitored. That includes like tigecycline or tetracycline. The one in the green bar, which showing a list of antibiotics that are considered to be safe to be used in myasthenia gravis. These are mainly like the beta-lactam antibiotic. So this is another table to demonstrate like the antifungal interacting with other medication. As you can see, the azole, they are like very potent enzyme inhibitor with the CYP. It does affect quite a lot of our routine medication like warfarin, statin. They will increase the exposure of them. Also, like digoxin, it will elevate the digoxin level, so monitoring is required. And like colchicine, it will increase the colchicine level. Then we will need to do like monitor the toxicity and try and we might need to consider dose reduction. So when we do the antifungal stewardship workaround, quite often we've seen the patient, hematology patient and oncology patient requiring chemo. There's quite a lot of chemo and azole interaction. So azole with vincristine actually increasing the vincristine toxicity and leading to neurotoxicity. There's also interaction with azole with the cyclophosphamide. They have synergistic hepatotoxicity. With voriconazole and posaconazole, they can increase the drug level of tacrolimus and cyclosporin by 3 times and double respectively. And voriconazole and omeprazole can increase the toxicity of voriconazole, therefore like therapeutic drug monitoring might require. So to summary, like there's many interaction with our diet and our underlying disease condition and medications. So antibiotic can be toxic and can cause harm. We need to consider the synergistic side effect and when we're starting antibiotic. I think that's it. Thank you.